and welcome to another episode of Low Tech Health. Let ourselves translate expert knowledge. Today is Wasabi Walnut, What's Hurting My Tummy Wednesday. And I'll tell you what's hurting my tummy. Laughing so hard. Patients have been saying and doing and mouthing and just the funniest things. So I've got this quad MS patient who's bedbound. He has a trach and a peg, but he's got a hell of a personality. He's very funny. He's pleasant, but he's a total care patient, so he has to have a lot of care. But he's very pleasant about it. Enjoys having his teeth brushed. Like enjoys oral care. He's not fighting you. He's very present-minded. Mouths words. You have to try to understand what he's saying. But I'm listening, auscultating his four quadrants of his bowels to listen to his bowel sounds, of his abdomen to listen to his bowel sounds. And I'm listening very closely because he's quite distended. In fact, it's the reason he's come to the hospital, is from being overpacked with stool and gas. So with that on top of a little flooded lung, might call it a collapsed lung if you were so inclined, he's in the hospital, in the ICU, off of his normal trach collar, which is just this collar that feeds oxygen into him because he's able to breathe, but now he's on a ventilator. So this is quite a change. So work needs to be done. It needs to be fixed. But Dad, I've decided that in my 40s, I'm going to become a doctor. I'm going to go back to school, I think. I'm certain of it. I'm going to do it. I'm going to do it, Dad. I don't know why I'm announcing that directly to you, but I want you to hear it. I just decided, I don't think I've talked to you about it, actually. Yeah, I'm going to do it because I would like to provide some care and to have the know-how and to continue learning, because there's just more to know and there's more to apply. And I already know there's a problem with hospital medicine and the way inpatient care is delivered, because we have to end up waiting for emergencies. And it's becoming a weird standard now because the acceptable parameters for what can cause an emergency have widened. We're allowing higher heart rates to just be chill, where we know we lose cardiac output above 120 beats per minute, but we're becoming okay with severely ill patients who've survived COVID being in the 140s, 150s, because they're basically anoxic at this point. There's no activity as far as a neurological standpoint. They're not following commands. They're not even able to breathe on their own. But we've continued all care because, unfortunately, family is not allowed to see their husband, son, father, baby. They can't see them. And yeah, everybody's somebody's baby. Damn it. And they're not allowed to see them, so it's been months. They don't know. They just saw grandpa, their dad, baby, son, wife, husband a few months ago, and they were normal. I mean, they probably were sedentary, maybe a little overweight, but they were talking to him. They were moving around. There was nothing that was ill appearing. So that to bedbound, unable to speak, move any limbs, or breathe on your own, with an extra hole in your neck and stomach and a tube in your urethra, without having seen any of it, without knowing that there's work, there's time, there's fear, there's panic, there's things involved in treating these emergencies, but there's no vision, there's no sight, there's no real proof of it other than a chart and other people's word for it. Because family being present is a big part of providing like a full code status. It's one of the most important things in inpatient hospital care. Up there with your name, allergies, code status. Are we doing everything? Are you a full code? Which means if your heart were to stop, we were to make your heart start again through CPR. And if you were to stop breathing for any reason, we would breathe for you. Or if you were unable to provide swallowing or swallow or for digestion and unable to make decisions for yourself, we could keep you alive through feeding tube. So that discussion kind of gets rushed in the beginning, and it is the most important signifier for your husband, father, baby, son, child, grandmother, father's whatever decides their care. And man, I don't know where I was going with it. Oh, the joke. That's right. I'm auscultating his bowel sounds, and I'm listening real hard because he's rather large. He can't speak, so I'm listening. And then I hear he's going. So funny because it's basically silent in there except for the TV. It's so weird. Interactions with, I've had quads for the past like 3 or 4 nights, and one has been the same for 4 nights. Well, they've been the same, but they've been my same patient 4 nights. And it's interesting how you just become accustomed to a way of caring and managing the time and providing sleep and like brushing his teeth when he goes to sleep and when he wakes up. His teeth look great. They're yellow. They're bright yellow. I'm going to put some whitening strips on them. Shine him up. Wish I could tell you his name, but that's a violation of HIPAA. He has an awesome name. Sounds like a superhero. Sounds like a superhero. Oh, and it turns out he used to be a volunteer firefighter. All really cool things. Neat guy. Anyways, what are we going to do to try to get family involved? How do we get them on the level of understanding the words we're saying? And do we use FaceTime? Do we have just a site? Is there a web page? Is there something we need to really break down to the public? Because a lot of them don't understand what pneumonia is. They don't really understand like oxygen. They get pain and they get that like hurting is bad, but a lot of times it's not crossing through that hurting causing you to hold your breath and then going towards a medicine that works, like opiates. It works to get rid of your pain, but it's gonna slow your breathing and slow your gut, and we're already kind of conditioned to not breathe deeply. It's a whole gap. It's a massive black hole of a gap with what people get and what they need as far as preventive care and actual health care. What is health care? Is it waiting until an accident happens and then treating them? Sure, that's health care, but getting sick is something that all effects really shouldn't happen. You should try your best to avoid it, and you should know the signs of moving towards sickness. Because when you come to the hospital and you've been moving towards sickness for many, many months, even many, many years, could be decades, and that is by a sedentary life and not eating well. I'll just keep it vague like that for right now because the main thing is circulatory issues from lack of perfusion, breathing, exercise, even just going for a walk every day, which is hard when you're trapped inside and you're told when you go out in the public you have to wear a mask because you want an exchange of oxygen that's unadulterated by too much moisture and a dirty mask. Who knows how often you clean it? And if it's too tight, just a constant rebreathing of carbon dioxide. I'm not saying spread it. Don't spread it. But know that you being alone somewhere in the park doesn't warrant you wearing a mask. You really need oxygen. You need oxygen to your brain because this little bugger, this virus, will turn you to cheese. It'll turn your brain, your body to cheese, and you'll really wish you were in the best health you possibly were, not in some just sad, sedentary, overly sedated state of acidosis, basically, because you're rebreathing carbonic or carbon dioxide. It goes into your bloodstream as carbonic acid. It's acidic. It makes your heart pissed off. It turns you into sauerkraut, basically, and you start to stink. You stink, and you get ill. And we know what smells bad. That's one. Pain. We get pain, and we get things that smell bad. Like smell bad and taste bad, which is ironic that COVID takes away your smell and taste, which I thought any big sinus infection takes away your smell and taste. How is this suddenly a cardinal sign of the biggest infection of the world in this century? I don't understand that because people lose their sense of smell and their taste a lot of the time, I will bet, when they're sick with a runny nose. It's not just COVID. Because people have been hearing that over and over. As soon as I couldn't smell anything, I knew it. It's like, yeah, but what did you try to smell? Did you? I don't know. It could be rebreathing your breath too. We're wearing masks all the time. There's a soft protocol and a recommendation that we wear the N95 the whole shift because I have a sneaking suspicion that we're not being swabbed well. And I don't know if this is true. And I probably should be less inclined to talk about it. But I think when you swab your throat, maybe I'll Google it right now. Throat, it's a little less accurate than the nose. Maybe I'm wrong. Let's find out in this very instant. Swabbing throat for COVID. Accuracy. Wonder how far it has to go down. Accuracy. Accuracy. Comparative. No discernible differences in viral loads or detection rates when comparing nasopharyngeal and oral pharyngeal. Oh, cool. All right. Cited by 23. Huh. And still, it might not collect it from your nose or throat. See. It's a head scratcher, folks. It really is. But in the grand scheme of things, you should be taking care of yourself day 1, day 2, day 3 before you contract a virus. You should know your blood type, really. You should be tested. Cassidy. What? I said you should know your blood type. I don't. She doesn't. She's a nurse. No one's ever told her. We test it when you come to the hospital. A type and screen is good for about 3 days. Guess what I'd like to say is treat yourself well. Get it in your bones and your movement that you need to breathe. You need to vasodilate. You need to open up the blood vessels and exchange oxygen, carbon dioxide. Let's take a few breaths. Yeah. You take some deep breaths. And I need to go to sleep. This is night 5 of 6. I got one more tonight. Yeehaw! Thank y'all for listening. I'll see you later. Love you.